Hi, I'm David Liew, reporting for RheumNow.com on this virtual ULR from the comfort of my home here in Melbourne, Australia. It's been fascinating to get used to this idea of the virtual conference, but I'd really like to tell you about some breakthrough abstracts that came out at this ULR about ANCA-Associated Vasculitis, one about therapy, and then one about predicting a relapse. Both two important clinical questions in our everyday practice with ANCA-Associated Vasculitis. There's been a lot of talk at this meeting around social media and in the actual lay media about Avacopan. Avacopan is an agent we've heard quite a bit about in previous meetings. It's a C5a receptor inhibitor, so inhibiting that element of the complement pathway and affecting that neutrophilic drive which underlies ANCA-Associated Vasculitis. We were lucky enough to see the results of the Advocate trial, the phase 3 trial in Avacopan in ANCA-Associated Vasculitis, presented by Peter Merkel on the first day of the conference, and subsequently it's going to be reported on the Sunday at the European Renal meeting as well by David Jane. So this looked at patients who were already receiving rituximab or cyclophosphamide for their ANCA-Associated Vasculitis, and was a double-blinded randomized control trial with Avacopan versus corticosteroids. That is to say, the Avacopan group, as protocol, didn't have steroids. So head-to-head, replacing that part of therapy. And it's quite exciting because that's something that we've always wanted to do. The idea of a steroid free regimen in ANCA-Associated Vasculitis is quite tempting. What we saw was that at 26 weeks, the outcomes were non-inferior, and the group that continued on another 26 weeks to 52 weeks actually had superior outcomes in the Avacopan group. And not only that, and of course you'd expect there to be a lower steroid burden in the Avacopan group. You'd expect there to be, which there was, obviously, you'd expect there to be lower steroid toxicity as judged by the glucocorticoid toxicity index that we have now come to, have become familiar with. We saw that lower as well, but we also saw better renal outcomes as well. Better renal function in the Avacopan group versus the steroid group. So this is really quite paradigm changing if we get to use it. This is the kind of thing which might replace our old friend steroids, which we know and love, but at the same time have a bit of loathing for, and this might actually change things. Now, of course, it comes down to cost. Corticosteroids are cheap. Avacopan, I suspect, will not be. But if the pricing's right, maybe this is something which we might see as standard of care in ANCA-Associated Vasculitis. Certainly, there's a lot of positive talk about it. The second abstract actually comes from an analysis of the MAINRITSAN 2 study in ANCA-Associated Vasculitis and looks at the idea of serum calprotectin. Now, I think a lot of us are familiar with the idea of fecal calprotectin to try and pick up inflammation or enteritic and colonic inflammation. What I think we're perhaps a little bit less familiar with is the idea of serum calprotectin, although it's been talked about a lot at ULR over the years in the context of things like early rheumatoid arthritis. It's a bit more sensitive than the inflammation markers, the peripheral blood inflammation markers that we're used to thinking about, like ESR and CRP. And that's the idea that maybe we might be able to pick up some of this subclinical inflammation that might predict the future relapses of disease. And so it's been looked at in as part of MAINRITSAN 2, it's collected there. And there's been data looking at early calprotectin predicting future relapse. But what this analysis from French colleagues looked at was actually the idea that serum calprotectin during that maintenance phase might actually predict relapse. And indeed, it did. It predicted outright relapse and it predicted renal function problems as well. So really, this was quite an enticing idea that right now, a lot of us are following ANCA titers, MPO PR3 titers, with the knowledge that they probably don't really predict anything, but that's something that we hold on to. We follow our inflammatory markers dutifully, and then other than that, we're just seeing the flares once they happen. with this, potentially we might be able to predict those flares as they're about to happen. And that's an exciting prospect as well. So 2 potentially game-changing abstracts here at EULAR 2020, virtually at EULAR 2020. Perhaps we'll see them in our practice in the future. Of course, it does come down to cost though. I'm David Liew, and for more, go to roomnow.com.